Center for Medicare and Medicaid in Baltimore, and headed up the quality initiatives a number of years ago, prior to coming back to Henry Ford. Since his retirement from Henry Ford, he's been working for the American Institute for Research, and is back involved with these large-scale collaborative improvement efforts again. So I'm very excited to hear his experiences in that domain. I think it's going to be really interesting to think about some of the issues involved in trying to do improvement at this scale. Thanks.
All right, thank you, Ian. So, kind of a combination of a little bit of history and talking through some points around the potential of innovation. So, first, the Deputy Director of Partnership Patients with CMS. And this is a program that was part of the Affordable Care Act, Section 125 of the Affordable Care Act. $500 million program trying to reduce hospital-acquired conditions. So, 30-day readmissions. And it started in 2011. And there were trying to recruit all hospitals in the country. They were successful in getting 1,300 hospitals, and that was about 88 all the hospitals in the country. So that's pretty good. And seeing various sections of involved off the National Coordinator of Health. The great collaboration to really align their program. And HRQ programs around people working team steps. And they really think that people that this is the best coverage operation across. So kind of the we also tried to begin everybody as kind of a positive. You know, every nurse the medical specialty group, we're all engaged and want to be part of this. For critical safety, the operations that are in, and anesthesiologists, we kind of work today. In medical safety, we have been from safety practices and health departments. We're very engaged. Very good at the work. Risk managers, their national conference, play participants, and then offices and and they were really into parts.
Hey, Jack.
We'll talk about that a little more specifically. CMS also very job really. So every one of the contractors had plans around patients and families. In most cases, didn't give their viewpoint commentary. Did it with patients as and patients were around here. We wanted to have hospitals think about having You're telling people that's the X and having a handoff and we have to choose our family advisory. So there was a really good need to have a involved in this.
Hey, Jai,
It started off with, these 12 types of harm. And
it's
then
not
later,
affecting the audio, right? So it says landline to our phone.
Yeah, so but if he turns off the camera, it'll smoother with because he's trying to run the slides. That's why I kicked this out of the Zoom.
We can't really hear the audio. It's just all black.
I personally, I don't know the audio button, just to make sure that it doesn't kick us out of like the Zoom again. Camera thing. I don't know if disconnecting the speaker and then just using the phone would be better.
If people reading on their own and feeling that's the key thing for hospital. Phoenix Rock Limbs would be either plastic. Which is a type of diarrhea that's caused by an organism that grows in your gut and can grow in your gut. And overuse of antibiotics could be a cause of that. And C is the real challenge because it can live on surfaces for a long time and it's very difficult to kill. So then there's also, we know what we want to accomplish. How are we going to, know we have an improvement? And it turned out there was already an existing medical system called the Medicare Patient Safety Monitoring System that was existing. And it was independent. A contractor came in and they would do 22 types of harm that they would do with thorough chart reviews, and they do this about 60 on a sample of hospitals across the country. And that was very handy for us because we didn't have to rely on turn in data that's all slightly different and put together. They could do whatever they want. And in fact, that was understood that it was really important to do. I just got a text from Ian. Turn off my camera. Okay. Was allowed to measure this however they wanted, and that was very controversial in a lot of people's minds. That they were thinking of this as research and not the everyone had to do this the same. And an example, I'll tell you why that was not useful. Many times, the only way people can do it the same is to have a least common denominator kind of thing that's the worst, lowest resolution thing possible. One of those hospitals that were working on it, being nurse magnet hospitals, they would participate in a thing called the National National Database of Nursing Quality Indicators. And they would do kind of every bed in the hospital check like once a month. Pressure injuries. And that was really the gold standard of doing it. But most hospitals didn't do that. Where they were, use that. It's the better way to do it, and that's really what you should be focusing on, what you're learning on. In other places, it's really, that's not as accurate and it's not as good as the common denominator. alignment of the measurement was not required. And why that was the case was that we wanted 3,700 hospitals or more. Had we forced everyone to say to participate, thou shalt measure it this exact way, we probably only would have got 500 or 600 hospitals, and that would have meant we would not have changed that 60,000 chart reviews up here for the whole country, because outcome for the country. So, but like I said, it added some advantages to us where you had places who could do things the better way, and we could also start teaching hospitals this is how they were able to do this a different way that was better, and we could spread the ability for other hospitals things going on in there. And as this went on in future years and iterations, it did help speed up adopting some of the that was very hard for people who came from a research mindset to get their head around that, to move the whole country, we did the same way. And that was such a saving grace having this independent national measure that we could actually use as our. Um, some other different things about this, I know, maybe the Rocket the luxury of being, the abused federal contractor. This was a bit different that most of these contractors were first time. And, we also had a consortium of children's hospitals. We had a group of academic hospitals. They had not been government contractors before, but they all came together with this, with a history, with passion related around patient safety. They really cared about this. Leading the organization, we wanted to really communicate with the contractors that if they don't succeed, we don't succeed. We're in this together. We're not adversarial where we're the federal government and we're paying you and we're here to jerk you around and abuse you, even though we did jerk them around. Um, and we also wanted to maintain that moral imperative. These people came to this because they cared about patient safety, and we always maintain that what we're here about is not are you meeting the minimum requirements of the contract with the federal government. What we're here about is we're giving you resources to make care safer and make the lives better for patients, and you want to get the maximum impact you can with the resources you have. Well, about saving lives and reducing harm. The other thing that was in this that was still to some degree controversial mindset, you can work on everything at once. You're constantly fighting with hospitals to say, well, we have to focus on the focus is on patient safety, and it's just morally wrong to say to someone, well, your mother was hurt this way, and that's not what we're so hospitals don't need to be focused on one or two. Maybe the pharmacy department, the ICUs might be working on one or two. The obstetricians, the mom and baby, the nurses there could be working on, a couple things. They're not all the same thing. They can all be engaged, and the hospital as a whole can be involved in 30 things at once. Get that mindset, because oftentimes you have like a quality director as the main kind of conduit into this, and they're like, well, I can't do 30 things at once. But your hospital can, and that's I think an important thing we did. That everyone has a role, and you should be having them engaged. Constant struggle to kind of keep that going and that mindset going. And I think as people found out that that does change the culture in the hospital and how much they can do around safety. One of the people who's involved in this was saying that, the more you do, the more you can do, and helping people kind of come to that. All of these change packages, and a lot of the message we came from CMS with this was find what works and get more of it. So we wanted them to really be assessing their network, finding out who does these things well, and have them be your teachers, have them be the faculty. They can talk with real, about this is what worked, this is what didn't, this was challenging for us. So each contractor had kind of change packages, and they were a little different, and they did tailor kind of things there that went. And we did have regular, across the whole program webinars that helped them share, what we tailoring was really needed because different states have had histories doing different things where they were successful or not, and so tailoring into what in their state or with the group of academic hospitals or children's hospitals, they all had different things to really think through. We had a support contractor that pulled things together, success stories, and helped produce webinars to really highlight those lessons. One of the key things to understand is that this was not a research program. Everything we were trying to do was to accelerate things. We're trying to speed up and spread how many hospitals are doing them in the best way, and to do PDSA cycles to really figure out, how can we do this the way we're supposed to be doing it, given the constraints we have in our hospital. Um, so it is very different than research. It is really more on the Everett Rogers kind of dissemination, accelerating the dissemination of innovation. That's really what we're trying to work through with them. So we did have 27 contractors, a lot of hospitals, multiple partners with things. We had high expectations for results. Kathleen Sebelius, who was the Secretary of Health and Super concerned about this program, which, so we were really had a big shining light on us, drawing attention to us and being good and bad. I mean, it was great because the federal agencies, within HHS were all aligned to be cooperative and working through this. It gets reported out once a month to the Secretary of Health and Human Services, which is rare for a program like this. And, cooperation wasn't really, if you're ever going to get sucked into the government to have to run a program, this is exactly what you would want it to be. So I was really lucky with that kind of work. We also tailored the program for special needs. That rural hospitals, we had a whole work group about what are the special things that rural hospitals need and how we can help them. Patient and family involvement in having them have a voice and be heard in this. A lot of these were tailoring it to the special histories you have going on with that. There was one contract that was all academic hospitals, and they're different children's hospitals. And then we had a group that was all safety net hospitals, so they have their, challenges, and then, my experience was all with both safety net and academic hospitals. It's big, but the world's very different in a very small hospital, but they have roles they can play. The thing about this is, 27 three-ring circuses at once. The whole collaborative model where they're working through this at once on multiple topics. And then we're trying to coordinate that with them and also bring in kind of the national partners, that can help them with expertise. And it goes both ways. We're really trying to accelerate what the American College of Surgeons are working on in this QIP. At the same time, we're working with multiple states on surgical site infections. So it's very complicated, dynamic, moving system. Incredible to see, and it seems at times like it's total chaos, but it was well coordinated. I'm going to go through a couple of the example things we worked through. So one was this early elective delivery. So before 39 weeks, to have an elective C-section or augmentation without any medical reason for reduction. Not uncommon for someone to schedule delivering because the doctor was going to go on vacation, and of course, the mom just loves me, and it would just be a tragedy if we got the second-rate doctor as my partner to deliver the baby for them. That was ridiculously commonly thought and told back in that time frame, and then that's far less so now, 15 years later. So do have higher rates of NICU use. They have respiratory problems oftentimes, and there's very slightly higher level of mortality. So the partnership with patients and the contractors, along with ACOG, the March of Dimes, American College of Nurse Midwives, began really this campaign to So part of this, you had a federal meeting to convene kind of these groups, and ACOG, midwife leaders, hospital executives, all on changing the practice and recommendations. And numerous contractors started working like across the getting the hospital CEOs to pledge that you are not allowed to schedule a delivery before 39 weeks without an approved what's appropriate, and these are the only ones we're going to allow. And develop kind of education for the hospitals or why they do that. Mark and Dimes had things out to moms and babies, the mothers kind of saying, this is why you really don't want to do this, it's safer for your baby. Spreading those kinds of things. Feedback to hospitals compared to their peers, where you can see, in the state, there's one hospital that seems to really be doing this a lot. So you can all your colleagues are cutting down this kind of practice. And sharing hospitals, from stories of success, they changed the minds of 2 or 3 physicians that had the practice of doing this. And so this is kind of you can see that it was around 11%, and just by a year and a half later, it dropped to substantial reductions in early elective deliveries. And I don't know what the numbers are like now. I'm not involved in this, but I know it's dropped quite a bit more since then. Though I am told there are occasionally people who stretch the diagnosis as kind of the rationale for doing it. The other big area was all the different infection control work. So all the groups had, change packages on, central line infection, CAUTI, ventilator care, CDIS, surgical site infection. Writing down what you should do and then getting it to be done in practice. Sharing stories. So one of the things like the surgical site infection, you want to start the antibiotics less than an hour before the surgery starts. And getting that coordination done in there of who does it, cleaning the site before surgery, giving the patient, for exiting soap shower with the day before they go in for surgery, effectively and reliably. There's for central line infections, there's a whole bundle of, like you're going to clean with chlorhexidine. That was pretty much well underway by this time, but there was a transition from using iodine to using a full drape, not just a tiny little drape over the spot where you're going to poke the central line in. And how central lines are very different. One of the other kind of things you're trying to weed out is practices that back in the early 2000s, it was still considered every medicine resident had to place at least 5 central lines in their realize that that's really not a good idea. If you're going to become a kind of doctor, if you're going to become, you're going through your regular medicine training, no point on having you do 5 floppy bad ones that you're learning how to do it. So that kind of mindset went away. So you did have people who were going to do it a lot, and they do it well, and not. Those kind of practices were part of what's kind of going on in this. Ventilator care, really stabilizing how that's done, so that you're doing it the same way. Every day you're checking to see if you can take the person off the ventilator or not. A lot of things that were changing and moving through things very quickly. And we shared stories about places their struggles. This is the PDSA cycle we did, and this is what we learned and how we with each and every one of these. And we're trying to always, it becomes natural sometimes for people to look for who's having find the people who nailed it, have it down. They're the ones who can teach everybody else to do it, and they are far more credible than you are. So really learning that kind of understanding your whole state, your well and things and who's struggling, and always leveraging those people who are doing well. And we challenge hospitals to adopt the did a very thorough job. But the hospitals we work through, you get people antibiotics with pneumonia, a number of other kind of things there. So again, lots of moving parts trying to really get people to do as many things as they could possibly do. Medication safety, we focused on three areas there because these really dominate. Glucose control, is very important in the hospital. Anticoagulants can be very dangerous. Back in 2011 or so, using a lot of warfarin. In patients, we had to move to the direct acting anticoagulants and opioids. Those were kind of the three that dominate your medication arm, and so really working through with that. So protocols, with hospitals and working through and making sure they're using long-acting insulin in the hospital, not just using coverage or short insulin. Sharing versions, for different types of nursing units. A number of hospitals in this time frame or soon after started doing things where patients can order meals whenever they want. Well, that screws up the ability to reliably time getting insulin before meals. So insulin drip protocols for the ICUs, so the timing of insulin and meal times can be very challenging depending on even local issues. It should work through that, and then also improving the documentation. Sharing kind of this is how we shared our documentation, and then now we can see what's going on. Again, warfarin dosing was mainly our thing back then, and now that's far less patients are taking warfarin. In big hospitals, you want to teach small hospitals, you don't have the pharmacist for that, and you don't have enough patients on it. So we have special tools for small hospitals how to do that and trying to tailor things and learning lessons from small hospitals as well. The hospital society was very engaged in this work, and also they later got really engaged on introducing the new drugs. And then shared tools on heparin drip protocols and the use of low molecular weight heparin, which again at this time was kind of coming off of very high cost and coming down, and now it's much cheaper. So these were all the kinds of things going on there. And with opioids, our focus was really in hospital inpatient use, not some of the things that came later about we had tools to include in that in training on pain questions, and we had various guardrails for pumps and how to program them and commonize that, and challenges around those issues. So again, a lot of various tools were doing that, and individual PDSAs for people trying to think through or learn from others that are in here. And then other kind of things that slipped into this, with we later had people working on some advanced topics. Things like, 15 years ago, it was not totally uncommon to have somebody say, well, why don't we just give some Benadryl to this person? Especially if they're already on opioids, they become delirious and they're not cognitively, things like that too. moving parts to do that. So this is how much the different kinds of things were reduced. Kind of hard, blurry to see here. You know, adverse drug events, we're down 13. Later dropped to 16%. CAUTIs were down 27%. CLABSIs were down. Sorry, I keep saying that. Falls down 8%. Obstetric adverse events were down 5%. Pressure ulcers were down 17%. Surgical site infections were down 18%. Ventilator associated blood clots, the DTE, the venous thromboembolism, were down 17%. So as an overall kind of thing, harms were down 16% in this. At this point, every single one of these things got better, and they got better by some reasonably large amounts. So it was this was probably the first and only giant success in the Center for Medicare and Medicaid Innovation. Kind of popped out of there. Those 60,000 chart review methods for doing things, you can kind of see the baseline. 2011 data. This didn't start till December 2011, so there really was no impact in this 2011. It was down to 142, and then the different times after this started, it dropped to 132, and then both down to 121 in 2013 and 2014. So substantial drop in this national sample measure for results. They broke out that MPS and that's kind of with a quarterly kind of trend too. Of course, it took quite a while for a year when it's quarterly. We have 3 months starting to pop out. When you're talking, we're talking about the whole country here, so that's a pretty phenomenal change in doing. One that's bringing in all the dollars. You can see, once it started, the actuary really said that they thought most of this was because of the penalties, but what's interesting is that doesn't follow non-participants in the other program, and we were getting better as much as they were. So, a challenge to give, again, the first time you've really seen a big move in readmissions. Successes were tremendous. So at the end of the first round of this program, and it came up with cumulative of just shy of $12 billion. And a year later, they got to do their final report where there was more time kind of looking at the after. And the official numbers then were that it avoided 2.1 million harm events. It saved 87,000 lives. And it saved $19.8 billion in costs. $500 million a year tax money, and it reduced costs by $19.8 billion. And a lot of that reducing costs was reducing costs for Medicare. This is a good spot for some questions because it kind of changes effort there. If you're there, Ian, if you had questions.
No, sorry. Just clear my throat.
Anybody in line?
Give me a second to pull it back up again. No, there are no questions.
Oh, wow. I went through that like a little bit of a fire drink from a fire. All right. and just kind of talking a little bit more toolkit mindset for you around speeding the rate of adoption. Think of this as kind of a framework to lay out for you to think about how you might take more advantage of but I'm also crosswalking it with the Protaska change model. So people may not be familiar with that, but it kind of states there are stages that are different for people you're trying to change based on where they're at. You're not really even aware there's an issue. You're so the first you want to move someone there, and then start contemplation where they're starting to think about, oh, well, maybe I need to stop thinking about making that change. And then, as a change agent, what you're trying to do then is to move them from contemplation to let's get you to prepare for making the change. And then the next stage is action. It also has relapse. We'll just kind of stick with those four parts of it. And then I want to crosswalk this with Herbert Rogers' kind of lessons on how to speed the music. And what he came up with is there were 5 items that you can use to how fast people adopt things. One is to show the relative advantage to things that it's obvious that their relative advantage is much better. Things faster. So you think about way back when we went from having landlines to cell phones. The relative advantage of carrying a phone with you was pretty obvious. And then is it compatible culturally? Is what you're doing here something that is very getting ideas like not rating or ranking people or not doing that. That's very challenging culturally as far as its compatibility. You struggle with that one, and that's going to slow up maybe people coming around to that. Simplicity. If you have something that's really complicated, that's usually slow to be adopted with things. And then the tryability. Is it something you can try on a small scale? You don't have to say, oh, I got to buy a very expensive item to do this. If you can try it, then that's very important. Which is somewhat like the relative advantage, but when you do it, you can observe the results fairly quickly. It's pretty easy to answer that question. So those 5 things Roger said, are what you want to do. So here's kind of laying out the grid. You as a change agent might want to move things along to help speed things up. So with relative advantage, when they're in the contemplation stage, you want to articulate to them the advantages and disadvantages, of both to the actors and clients. You want them to kind of see, start that little list of what is it better or worse, and then when they're at an action stage, you want to move them along to developing a simple measurement or an observation method that can, make that advantage apparent. So, once you've talked about what the advantage is, then can you turn that into a simple way to say, after you've tried it, let's reflect upon that advantage and, and have the questions ready or the measurement ready that can, really shine a light on that. And then implementation, transparently kind of share the results. Encourage debriefing, afterwards about the success or failure of the work. Make the action, and remediate problems that they're identifying. And then confirmation, tell the story and share the data. Support your organization. Again, kind of keep people moving. And because this was just the story of the Partnership for Patients was really just about juggling 100 balls at once and really trying to keep hundreds of people moving forward all the time, and really encouraging the contractors to be doing that as well. So pay attention to the multiple points of view. The cultures and symptoms. If you're not familiar with Everett Rogers, one of the things we talked about that came from that book as well. So, with the compatibility too, that might also be kind of searching out who might be the early adopters because they're going to be a little bit less worried about the compatibility kind of item. Seek to understand before. The big things about valuable sources. And today maybe that's some of the things we need to really talk about with some of the scary stuff of people being afraid of getting flu shots every year and such. That for whatever reason it's not culturally compatible. Help people come through with that. Um, have the client communicate to peers. This is and hopefully you can kind of share, their success with their finding the credible source of the people that can get past kind of that cultural compatibility challenges to help them get to taking. Having an honest assessment if something's complex, um, you know, don't try to lie about it. Find someone already doing the complex thing, and help them communicate. Then really think through how to develop the smallest scale change that's humanly possible with something that's not and that can take some work and effort. But if you want to get someone to try it, you want to try it at the smallest scale you can possibly do. You want to listen to feedback. Again, triability. Some of the things are really easy to try, and other things aren't. But helping people, do that. I mean, you can't try an electronic medical record. I mean, you're going to jump all in, you're going to do it, or you're not. So that was one of those kind of things where. But again, the smallest scale possible. Listen to concerns and help the client kind of modify their plan. Start with the assumption that the goal is better, not perfect. That's often very important in the kind of issues and things. And then again, make the measurement simple and fast. Debrief again with this to help get the you may have to kind of point out that work much better. Or in general, I think this is just kind of a strategy to help kind of get people to be changing, to be a change agent and help people think jumping to decision and not realizing the fast recognize their pre-contemplation and get them to move to thinking about it first and then get them to move to actually trying it. And then the other challenge is always no one has enough resources to do the work. So making the case locally is always important. Understand your requests. Think like the reviewer and understanding the needs of the organization. Crosswalk your ideas with your requirements. Again, you take a lot of resources to do a small test. Um, um, and then backfill once it's funded. I expected to have a few more questions earlier on, so this is my former boss. Taylor asking the question, can I come in? Very cute. I'm happy to have any questions or comments or just thoughts about that was a federal thing that was success you had no idea about. Probably more of those than you realize.
I think it's wonderful to see kind of an example of that scale of improvement activity that that most people would, very few people have any awareness of. It would be great for a lot more people to be aware of that type of government effectiveness. And I mean, it's just, that's an incredible number of lives saved and harm avoided, and financial impact too.
I was curious what kind of time they were projecting that savings was over. Is that for 10 years or, you know?
No, that was actually over the 2011 and the end of 2014.
So during the time of the project and of the studies. Oh, interesting. That's far larger than I thought. I figured that was some sort of, based on what was discovered and the, I'll call it harm saving measures put in place, that then they were, right? Because lots of times then you forecast that will result in saving X amount of lives or injuries or dollars in 5 years, in over the course of the next 10 years. But that was actually what they thought the savings was literally during the 3 years or so that it was in.
Yeah, and those numbers were validated by the Office of the Actuary, and I can tell you, have sitting in meetings with them, that's not something that's a give me.
Right.
But to give you an idea, every bloodstream infection that's avoided saves $48,000. They're expensive to treat. Every readmission, but you're talking thousands of readmissions there, was around $12,000, I think. I don't have the number in front of me on that. Every pressure failure associated pneumonia is 47. So when you're staying across the whole country,
So how sticky do you think the changes, the improvements were? Do you think kind of the path of improvement was continued post project?
yeah. We did have some backsliding during COVID. Things got worse, especially the bloodstream infections. C. diff has continued to get better and better and better. I think some of the C. diff, though, was at the end of 2019. Triclosan was removed from soap and they replaced it with other antimicrobials. So they rebalanced the infections. They do it every couple of years. These were all done on the 2008 method. So they tweaked the definitions and they normalized them in 2015. So in 2015, C. diff has fallen 60%. Collapsing down to, I think, about 0.7. So it's down 30% since 2015. So a number of these have kept getting better. And there have been continuations of this program, other phases afterwards. So a lot of the infections have gotten better. Surgical site infections have kind of leveled off. They have not gotten better. And I don't know about pressure injuries. They've kind of leveled off as well. So you haven't had quite the same level of energy. And like I said, there was a number of these that have been recovering. Yeah, you're a lot less likely to get an infection in the hospital now than you were 15 years ago.
Well, that wasn't C. diff one of those areas where they were really worried about kind of the antibiotic resistance and that it was going to become just untreatable at some point?
Actually, I don't think they've had problems with very high. But it is caused, C. diff is caused by overuse of antibiotics because the antibiotics will kill the bugs in your gut that keep the C. diff at bay. So that's one of the challenges with C. diff is that if you're using too many antibiotics, you get C. diff out there may very well be that because you're having to use multiple kinds of antibiotics.
Any other questions?
I don't think so. That was very interesting. I didn't know anything about. There's lots of initiatives out there that we don't know anything about, but that was a very interesting one to hear.
Yeah. Yeah, I'm very grateful that Don Berwick recruited me to CMS to do this. It was the most fun thing I ever did in my life. It was a lot of work.
Yeah, I mean, just the size of the program, sort of with all the different hospitals and then the different departments within the hospitals, because you were studying different things within each. Just a massive coordination effort.
So I hope I convinced you that.
Let me get out my checkbook.
Sounds like, well, and unlike most of those questions, that had a pretty good return on investment. Right? It's pretty clear. Verified by the deep state actuaries and accountants.
Yeah. As a group, they were very non-partisan. They were very good, but they were tough. I mean, they did not want to give us credit for the early elective delivery thing, even though they're full of crap, because I know that.
Cool. Well, thank you very much, Jack, and really appreciate you taking the time to share this with us.
My pleasure. Enjoy the rest of your day out there in sunny California.
We'll do our best.
Thank you.
It's a hard job, but somebody has to do it. Thanks, mate.
All right. Have a great day.
Thanks. You too.